This is the Nutrition During Lactation module. My name is Kimberly Prezioso, and I am a registered dietitian nutritionist and a certified lactation educator. My scope of practice has always revolved around the prenatal and pediatric period of the life cycle, and a primary focus of mine is to really look at variety, balance, and moderation when it comes to healthy eating. You've already heard my professional story, my personal one. Well, in terms of pregnancy and lactation, I can say that I've almost done it all. I've breastfed multiples and I've breastfed a single. I've breastfed a term baby as well as preemies, although at 7 pounds 4 ounces and 6 pounds 9 ounces, it was kind of hard to consider them preemies. I've had babies in the NICU and I've had babies that have come home right away. I've had a jaundiced baby, and I've also had babies who, after being breastfed once and then took a bottle in the NICU, never ever latched on again. And yes, he is still that stubborn today. And I've had babies who really couldn't have cared less how they received their feeding, just as long as they received a feeding. So I've also had a baby who, after fixing an ineffective suck and having to use a supplemental feeding system for a couple of weeks, refused to drink anything other than breast milk from the breast for almost 14 months. And she as well is still pretty headstrong. So I do have varied practical experience, as well as my certificate in lactation education from UCLA, and years of experience working with pregnant and breastfeeding women in the WIC program at Northeast Valley Health Corporation. That being said, I am fortunate to be a part of this course where you will be given the background and tools to be effective educators and advocates for breastfeeding. And whether you have breastfeeding experience or not, enthusiasm combined with sound knowledge will allow you to make a real and lasting difference in the lives of women, children, and their families as you help them in their breastfeeding endeavors. This is a great quote to keep in mind when you look at pregnancy and lactation. So, the 1,000 days between a woman's pregnancy and her child's second birthday offer a unique window of opportunity to build healthier and more prosperous futures. By the end of the session, the student will be able to describe the nutritional needs of the lactating mother, identify how a lactating woman's diet is different from a healthy diet for a woman of the same age, including special consideration for lactating teen moms, identify levels of individual nutrients in lactating women's diets that affects the quantity of those nutrients in the breast milk, counsel mothers in determining whether particular foods might affect breast milk, and describe the weight loss recommendations for lactating women. By the end of the session, the student will also be able to understand how to safely lose weight while breastfeeding, describe the impact vegetarianism may have on breast milk and the breastfeeding infant, identify the foods a lactating woman should avoid, describe the impact that eating disorders may have on breast milk, describe the impact that maternal diet can have on breast milk, also evaluate the need for referral to health professionals. So, an overview of the course. We will be looking at calorie needs, weight loss and gain, nutritional assessments, general nutrition, special considerations, and making healthy food choices. Nutrition during pregnancy and lactation and in the first years of a child's life provides the essential building blocks for brain development, healthy growth, and a strong immune system. In fact, a growing body of scientific evidence shows that the foundations of a person's lifelong health, including their predisposition to obesity and certain chronic diseases, are largely set during the 1,000-day window that I referred to earlier in the quote. It is why it is critical that women and children get the right nutrition during this time, and that starts with the right nutrition information. Malnutrition early in life can cause irreversible damage to children's brain development and their physical growth, leading to a diminished capacity to learn, poor performance in school, greater susceptibility to infection and disease, and a lifetime of lost earning potential. It can even put them at increased risk of developing illnesses like heart disease, diabetes, and certain cancers later in life. The impact of poor nutrition early in life has lasting effects that can transcend generations, and this is seen throughout the world as malnourished women give birth to malnourished daughters who grow up to become malnourished mothers themselves, thereby perpetuating the cycle. Globally, the damage done by malnutrition during the first years of a child's life translates into a huge economic burden for countries, costing billions of dollars in lost productivity and avoidable healthcare costs. However, by focusing on improving nutrition during the critical first 1,000 days, much of the serious and irreparable damage caused by hunger and malnutrition can be prevented. Again, the 1,000-day theories, it's the 1,000 days between a woman's pregnancy and her child's second birthday. And that offers a unique window of opportunity to build healthier and more prosperous futures. Improving nutrition for mothers and children during the 1,000-day window helps ensure children get the best start to life and the opportunity to reach their full potential. And health experts agree that improving nutrition during those critical 1,000-day windows is vital. So the right nutrition during the 1,000-day window helps build a child's brain and fuel their growth, improve a child's school readiness and educational achievement, reduce disparities in health, education, and earning potential, reduce a person's risk of developing chronic diseases such as diabetes and heart disease later in life, save more than 1 million lives each year globally, boost a country's GDP by as much as 12%, and break the intergenerational cycle of poverty. Research is showing more and more that we are what we eat, and we are what our mothers ate and what her mother ate. And that being said, although high-quality nutrition leads to high-quality health, an imperfect diet still leads to breast milk being the perfect food for babies with very few exceptions. The key is optimizing health and helping families make sound decisions that will last a lifetime. Exclusive breastfeeding is a cornerstone of child survival and child health because it provides essential, irreplaceable nutrition for a child's growth and development. Nonetheless, just 38% of infants are exclusively breastfed in the first 6 months of life globally. And even though breastfeeding rates in the U.S. are climbing, the CDC reported in their last, breastfeeding report card that even though 79% of newborn infants started to breastfeed, breastfeeding did not continue for as long as recommended. And you can visit the CDC website to view those statistics. And in California, the statistics are pretty low as well. Exclusive breastfeeding has been shown to have the single largest potential impact on child survival of any preventative intervention. Besides serving as a child's first immunization, providing protection from respiratory infections, diarrheal disease, and other potentially life-threatening illnesses, exclusive breastfeeding also has a protective effect against obesity and certain non-communicable diseases later in life. So let's start right off. Breastfeeding mothers generally need more calories to meet their nutritional needs while breastfeeding. An additional 450 to 500 calories of healthy food calories per day is generally the cost of exclusively breastfeeding each day. The calories come from food as well as from fat stores. The calorie cost of 1 liter of breast milk is approximately 940 calories. Now, most women produce 750 mLs a day. Again, that's an average. Each milliliter is about 0.67 calories plus the metabolic cost of synthesis. And, most infants consume around 19 to 30 ounces a day with the cost of, around 380 to 600 calories a day. Examples of 500 calories per day include a peanut butter and jelly sandwich, a plain bagel with 3 ounces of cream cheese, and that's, the 2 halves. That's a Big Mac. That would be 2 street tacos with a small side of rice. To review, BMI is a measure of an individual's percentage of probable body fat based on gender, height, and weight. It is an imperfect measure, as one is not actually measuring the amount of adipose tissue versus muscle tissue, although it is a generally accepted and easy way to measure. It should only be used after the age of 20. There are other measurement standards for children and teens, such as BMI for age or weight percentiles. Both underweight and overweight status do indicate malnutrition, and both can and do impact breastfeeding. If a woman is of a normal BMI postpartum, an intake of approximately 2,300 to 2,500 calories per day for breastfeeding women versus 1,800 to 2,000 calories a day for moderately active non-pregnant women who are not breastfeeding is sufficient. The number of additional calories needed for an individual breastfeeding woman is also affected by her age, body mass index, activity level, and extent of breastfeeding, meaning exclusively breastfeeding versus a combination of breastfeeding and formula feeding. Women may need even more calories if they exercise vigorously or for long extended periods of time, if they are underweight, or if they are breastfeeding multiples. Women who are underweight are less likely to initiate breastfeeding, especially if the mom is a teen. An underweight individual may be underweight due to a number of factors, such as food insecurity or disordered eating patterns. Obesity leads to increased health risks, diabetes, hypertension, cardiovascular disease, and more. What many mothers do not consider is the hindrance it may be to breastfeeding. Obese women have 4 times the risk of not initiating breastfeeding. 4 times. Research has demonstrated that obesity may delay the onset of breast milk, as well as a delay in the prolactin response to sucking. Women who are overweight or obese during lactation also need special support. While they may have a healthy diet, there are other considerations. They may have delayed lactogenesis too, which may result in needing additional support and information during the colostral phase. Similarly, a C-section due to overweight or obesity may also delay lactogenesis. And although lactation may provide a benefit of weight loss to obese or overweight women, obese women statistically are less likely to initiate and maintain lactation, like we said earlier, due to either birth complications and or short or flat nipples, usually due to oversized breasts. Additionally, the typical American diet often falls short in vitamins A, E, C, and folate. If an obese client's diet is mainstream, these are also nutrients to look out for. Again, being at a healthy weight prior to pregnancy increases the chance for a successful pregnancy and breastfeeding experience. As well, women who are overweight or obese during pregnancy tend to have large babies, and the larger macrosomic babies tend to breastfeed for less of a period of time. Some of the complications due to obesity during pregnancy include spontaneous miscarriage, birth defects, limitations to ultrasound, gestational diabetes, hypertensive disease, stillbirth, and fetal growth abnormalities. And even though this is a slide related to pregnancy, I am including it because all of these issues or situations do have an impact on lactation. Complications due to obesity during labor and delivery, well, those can include difficulty monitoring the baby, a C-section, a decreased success of a vaginal birth after a cesarean delivery. Also, there can be difficulty with anesthesia. During the postpartum complications, there can be complications including postpartum hemorrhaging, wound infection, obesity in the offspring, long-term health issues, and malnutrition, including vitamin and mineral deficiencies. Keep in mind what I have mentioned before. Appropriate weight gain during pregnancy and being an appropriate weight prior to pregnancy is critical for a number of reasons. Returning to a healthy pre-pregnancy weight is also important, and breastfeeding can help. As with pregnancy, pre-pregnancy health, including weight, physical activity, and eating patterns, matter in lactation. In lactation, the consideration also includes pregnancy health, including, you guessed it, weight gain, physical activity, and eating patterns. Poor intake during pregnancy can lead to a multitude of barriers to overcome. Although being a mother is challenging, lactation is a normal physiological process. Women are entirely able to adapt. There are generally no major shifts in eating patterns, especially if healthy choices were part of the everyday lifestyle pre-conception and during pregnancy. All women should aim to eat well for themselves as well as their families, but should not become overly concerned or obsessed with healthy eating to the point that it becomes unhealthy. The goal is to eat well, not perfectly most of the time. The body becomes more efficient at utilizing energy and utilizing certain nutrients during pregnancy and lactation, which can boost overall health and nutritional stores of certain nutrients. Women should eat a variety of foods following the recommendations of the dietary guidelines. USDA MyPlate, which I have included in the resource page and I have discussed in the Basic Nutrition and Nutrition Education module, as well as the Nutrition During Pregnancy module, has suggestions for moms, even vegetarian moms or those looking for Mediterranean diet plans. They even have great tips on budget-friendly grocery shopping and food plans. Now, looking at hydration, hydration is important for everyone, and women should trust their thirst to guide them. During lactation, a low intake will result in less urine output rather than less milk production. There is little research to support that an increase in water will increase the volume of human milk, only that excess hydration may decrease human milk output. A helpful suggestion: have breastfeeding moms remember to think about a glass of water with every feed. They may not need it, but they should consider it. Water should be considered first, but milk and juice also count. Also counting, coffee, tea, soda, and other beverages. Those can be included in the overall count. Although women shouldn't breastfeed solely for weight loss, it's hard to argue that it is a pretty fantastic benefit. And it's one more way that the body is preparing for possibly the next pregnancy, or at the very least, the best chance at keeping up with a busy toddler. Weight loss is individualized, although it is more likely to happen for women who breastfeed. Weight loss is dependent on activity level, food selection, calories, individual metabolism, and more. The general composition of a breastfeeding eating pattern is, starting with carbohydrates, those should comprise about 50 to 55% of the diet, including 50% from whole grains. Protein should be around 12 to 15% of the diet, and that's around 1 gram of protein per kilogram of a normal weight. And fats, well, fats should make up about 20 to 30% of a healthy diet, and women should be encouraged to choose healthy fats like polyunsaturated fish or a monounsaturated avocado. Again, we're limiting saturated fats and we are limiting the trans fats. This is the first test your knowledge slide of the module. And so again, I'll read the question and wait about 10 seconds, and then we'll go over the answers. How can obesity affect breastfeeding? Well, during pregnancy, which can affect breastfeeding, if a woman is obese, she may suffer from spontaneously miscarrying her baby. There are other birth defects. There are limitations to the ability to do a proper ultrasound. Gestational diabetes may occur. She may become hypertensive. She may have a stillbirth child, and there may be fetal growth abnormalities. Now, during labor and delivery, there can be difficulty in monitoring the baby. She may have to have a C-section, and there may be decreased success of a vaginal birth after a cesarean delivery. And again, there may be difficulty in administering the anesthesia. Postpartum complications include the possibility of hemorrhaging in the postpartum period, wound infection, obesity in offspring, long-term health issues, and malnutrition, including vitamin and mineral deficiencies. Based on our previous discussions, which of the nutrients below may be lacking in the diet of a vegetarian? So protein, vitamin B12, calcium, and iron are all nutrients of concern when looking at a vegetarian diet. So protein needs during lactation. Let's look a little bit more closely at protein. So protein needs stay fairly stable throughout the entire year at about 71 grams per day. And the requirements have gone up a little bit. They used to be lower. However, the true protein requirement is based on 1.05 grams per kilogram per day. So if you do the math there, a 120-pound woman may have a protein requirement of around 57 grams per day, which is less than what's stated on the slide. A 150-pound woman will be slightly higher, and that's where the 71 grams per day would come into play. Again, it's always better to do the measurement just so that you're getting an accurate count. To give you an idea of protein content, one egg will have approximately 6 grams of protein. A 4-ounce chicken breast, around 25 grams. When you're looking at sources of protein for a healthy diet, you want to look at and include all of the sources. You want iron-rich protein like beans and lentils and eggs, lean chicken, turkey, beef, pork, fish. You want calcium-rich protein like non-fat or low-fat yogurts, cheese, and milk. You want to include plant-based protein like beans, tofu, and lentils. And again, looking at all of the different sources of protein, that will help you ensure balance, variety, and moderation in obtaining all necessary nutrients. So during lactation, 20 to 35% of total calories can come from fat. The general guidelines are to limit saturated fats like butter or higher fat meats. You want to limit trans fats like margarine. You want to remember to read the food labels, although by the end of 2018, those should be mostly phased out. You want to encourage unsaturated healthy fats like avocados and nuts and seeds. And you also want to encourage the omega-3 fatty acids, especially those from the non-mercury seafood over supplements. You can always refer back to the basic nutrition and nutrition education module because those go into a lot of these definitions and food choices extensively. Remember that fat does have a vital role in the body's ability to store energy, facilitate hormone production, help protein function, nourish vital organs, and synthesize and store vitamins. And the essential fatty acids must be obtained through the diet. Omega-3 fatty acids help control blood clotting and build cell membranes in the brain. Human milk fatty acids are synthesized directly from the body's stores of omega-3 fatty acids, which we obtain through the diet. Earlier you saw that there is actually a recommended amount of omega-3 for lactation. The level is 1.3 with a range of 0.6 to 1.2 grams a day. So we just wrapped up protein and fat, and so this is a good time to look quickly at fish. So a side note, one form of a vegetarian diet is a pescatarian diet, where individuals consume fish but no meat or poultry. Now, seafood is being more closely looked at due to contaminants that can be long-lasting. We've talked about mercury, and mercury especially can damage an unborn baby or a young child's brain and nervous system. That being said, the issue in the U.S. is generally not eating enough fish. So let's look at the benefits and the risks. So we've said that fish is an excellent source of protein. It provides several vitamins and minerals and is low in saturated fat, and all of which are excellent attributes for being healthy. Omega-3s that are present in fish ramp up the health aspect by potentially reducing the risk of premature delivery and improving brain and vision development in the baby. In 2016, the U.S. Food and Drug Administration, as well as the Environmental Protection Agency, released an Advice About Eating Fish chart to help women and parents understand good seafood choices. The initiative recommends that all women of childbearing age, especially those who are pregnant or breastfeeding, consume 2 to 3 servings of fish per week from the Best Choices list. That Best Choices list includes the 4 fish listed on the slide, the fish under the 2 to 3 servings of 4 ounces each week. Those fish include catfish, cod, salmon, and sardines. The fishes to avoid are king mackerel, marlin, orange roughy, shark, swordfish, tilefish, and big-eye tuna. And obviously these are to be avoided because these are highest in mercury levels. So even though fish is a great source of omega-3 fatty acids, supplements are widely available and they are widely taken. And if you are taking a supplement, you do actually want to look for mercury-free fish oil. Algae oil works as well. And other omega-3 sources include walnuts, flaxseed, and canola oil. And as we're finishing up the macronutrient portion of the nutrition during lactation, carbohydrates should be around 210 grams a day. Remember, that's the biggest part of the daily caloric intake. And I know I say this repeatedly, that half of the grain intake should be whole. And you want to especially limit added sugars. What role do omega-3 fatty acids play in the diet of a breastfeeding mom? And why are omega-3 fatty acids important to babies? So, human milk fatty acids are synthesized directly from the body's stores of omega-3 fatty acids, which are obtained through the diet. Omega-3 fatty acids are important to babies for brain and nerve development, immunity, and eye development. What are 3 sources of omega-3 fatty acids? Well, I've listed several, but 3 sources of omega-3 fatty acids include catfish, cod, salmon, sardines, and supplements like mercury-free fish oil and algae oil. Other omega-3 sources include walnuts, flaxseed, and canola oil. The consumption of more food to meet energy needs and the increased absorption and efficiency of nutrient utilization that occurs during pregnancy are generally adequate to meet the needs for most nutrients when good food choices are made. Again, when there's balance, variety, and moderation in play. There are a few exceptions. However, vitamin and mineral supplementation is routine and is even more important in vulnerable cases, including food insecurity, alcohol, tobacco, or other substance dependency. Supplementation is also important in cases of anemia, in a strict vegetarian or a vegan diet, or when there are simply poor eating habits. Reinstitution of prenatal nutrition supplementation is fine, but in general, regular supplements during the lactation period that meet all of the 100% daily requirements is probably a better choice. Again, women can always check with their healthcare providers and let them know of all supplements taken. Many women consume less than the recommended amounts of calcium, magnesium, zinc, vitamin B6, and folate. And many new mothers may have stopped taking their prenatal vitamin. If a nutritional deficit is suspected, prenatal supplements generally do not include a significant amount of calcium. And in addition, during lactation, 250 to 350 milligrams of calcium is transferred daily from the mother to the neonate through breast milk. Patients should be apprised of the need for additional supplementation to meet the requirement for this key mineral. It is important to emphasize that vitamin and mineral supplementation cannot replace a healthy diet. It's also important to recognize what we mentioned earlier, that variety in a diet is key. Variety is what allows all of us to consume the full scope of vitamins, minerals, and nutrients. A varied diet provides a varied nutrient base. So let's take a look at a typical supplement as compared to the percent daily value. As you can see from the slide, and it should be noted that not all nutrients are included, if women continue taking their prenatal supplements during lactation, they are ensuring for the most part that they are pretty close to meeting the daily recommended amount. And of course, that doesn't account for food eaten. A general multivitamin or mineral supplement is recommended once a day if it doesn't exceed the daily intake by more than 20%. And that's important. A lot of supplements, when you look at the label, go way beyond 20%. One thing to consider that doesn't come into play a lot is that during times of disasters, such as hurricanes on the East Coast or, blizzards in the Northeast, tornadoes in the Midwest, earthquakes, in California, the World Health Organization does recommend a daily micronutrient supplement during emergency or disaster situations for pregnant and lactating women, especially in regards to iron and folacin, and that's just something to keep in mind. Looking at the table, the components are on the left, so it lists a few vitamins, a few minerals as well. It lists what the amount is in a typical supplement and what the form of that vitamin or mineral is found in. So if you look at vitamin A, The vitamin A in a supplement is going to be in the form of beta carotene, and that would be in the amount of around 4,000 international units. And vitamin D3 would be found as cholecalciferol. Vitamin B12 would be cyanocobalamin. Vitamin C is ascorbic acid. Zinc as zinc oxide. So again, different micronutrients come in different forms in supplements. So as you can see on the right-hand column, that includes the percent daily value for pregnant and lactating women. So if you look at vitamin A, around 50% of vitamin A would be provided in this supplement. You would receive 100% of vitamin D3 in this particular supplement. Vitamin E is pretty low, but folic acid you'd be getting 100%. So it's important to look at the label of any supplement that a client is considering taking and really evaluate whether or not it truly is the best choice of a supplement for them. So looking at pregnancy versus lactation, looking at the macronutrients. So again, this is a table that is going to show the movement of a macronutrient from pregnancy to lactation. So the first one, we look at a rise in carbohydrates. So during pregnancy, there's really only around 175 grams needed per day. Again, that's an average. And that bumps up to around 210 grams per day in lactation. So fiber also is bumped up as well, not by a lot, but it does go from around 28 grams per day to around 29 grams per day. And if you'll remember earlier, we did mention that fiber is one of those nutrients that is sorely lacking in the American diet. And in fact, the typical American diet really only does provide around 15 grams per day. So if we're looking at the polyunsaturated fatty acids, the omega-6s, those remain stable from pregnancy to lactation. And if you look at the omega-3s right below, those actually drop, and those go from 1.4 grams per day to 1.3 grams per day. And protein remains the same from pregnancy through lactation. Now water, you can see that water jumps up a lot. So even in pregnancy, around 3 liters a day or 11 to 12 cups is what is recommended. And then if you look at lactation, you're almost up to 4 liters a day, and that's from 14 to 16 cups on a daily basis. And that's why it's really important for women to get in the habit of really drinking water throughout the day at meals and at snacks, and just considering that at every meal or snack to drink some water. Keep in mind that weight loss during lactation does not usually impact the quantity or quality of breast milk. But maternal deficiencies in magnesium, vitamin B6, folate, calcium, and zinc have been described during lactation, as we mentioned earlier. Both fat, such as vitamins A, D, and K, as well as water-soluble vitamins, specifically vitamin C, B1, B6, B12, and folate, are secreted into breast milk, and their levels are reduced in breast milk when there's a maternal vitamin deficiency. Not just if it's a little low, but if there's a specific deficiency. Fortunately, these vitamin deficiencies in breast milk respond to maternal supplementation. So on the other hand, calcium, phosphorus, and magnesium levels in breast milk are independent of maternal serum levels and diet. Maternal factors such as stress, anxiety, and smoking can decrease milk production, but the quantitative and caloric value of breast milk does not change with dieting and exercise. Continuing on, just to highlight, you can see in green where nutrients decrease during breastfeeding. In red, they are increased. Black, they remain the same. And in fact, in some nutrients like vitamins A, C, chromium, copper, and iodine, these are needed in quantities nearly double that of a non-breastfeeding woman. So as you can see, looking down the chart, thiamine requirements from pregnancy to lactation remain the same. Riboflavin, vitamin B6, vitamin B12, and vitamin C, those requirements are all elevated during lactation. For niacin and folate, those actually decrease slightly from pregnancy to lactation. If you look at vitamins A and E, those micronutrients need to be elevated during the period of lactation, and vitamin D remains the same. Vitamin K also remains the same as well. That is just not included on the slide. So when we're looking at pregnancy versus lactation, when you look at the minerals, and again, I've only included about half of the minerals just to demonstrate how a lot of the nutrients are increased during the lactation stage. If you look at calcium, calcium remains the same. You're going to have the same requirements in the prenatal period as in the lactation period. Although the thing that is different for a lot of these is that the needs are higher when the mom is 18. So if you look at iodine, zinc, and potassium, all four of those minerals have increased requirements during breastfeeding. And for iron and magnesium, well, those, as you can see from the table, those requirements drop. Those are higher in pregnancy than when you look at lactation. One thing that I feel it's important to comment on at this point in the slide is just the changes over time that I've seen in terms of the macronutrient and micronutrient requirements. So it is really critical that as professionals that you remain up to date with your information, whether it's lactation information, nutrition information, health information. It's really important that you stay current. One way to do it is by, at the very least, by reviewing the dietary guidelines that come out every 5 years. These numbers have changed over the years, just in the years that I've been a dietitian, and I know that these numbers will continue to change over time. So these are the nutrients affected by low maternal status, but they can respond quickly to reversal. Vitamin A, D, K, thiamine, riboflavin, vitamin B6, vitamin B12, vitamin C, selenium, choline, and iodine. And I could talk about each one of these individually, but for the purposes of this course, it's just important that you know that these are some of the nutrients that may be affected if a mom isn't including enough of these food sources in her diet. And again, this is where balance, variety, and moderation come into play. Nutrients that are not affected by low maternal status are folate, zinc, iron, calcium, phosphorus, magnesium, and copper. When discussing carbohydrates, what are 3 things to remember? Well, keep in mind that around 210 grams a day, and this is up from the prenatal stage, is appropriate. Around 45 to 65% of daily calories should come from carbohydrates, and about half of the grain intake should be whole. Limiting added sugars is important, as all added sugars really do is contribute empty calories without any other nutrition. On average, breastfeeding has a calorie cost of what per day for a single baby? So on average, breastfeeding costs around 500 calories a day. To prevent neural tube defects, all women of childbearing age should consume 400 micrograms per day of folate from fortified foods like cereals and other grains or supplements, or preferably both. And beginning 1 month before conception, women should really boost their intake and eat folate from foods in a varied diet that reaches around 500 micrograms a day. And that's the perfect scenario. However, remember that I've said this before, that 50% of all American pregnancies are unplanned. You can see the increased levels recommended for pregnant and lactating women as compared to just non-pregnant, non-lactating women. Many lactating women, actually all lactating women, should be viewed as pre-pregnant women. One thing to keep in mind is that the critical time when the neural tube defect is happening is frequently prior to or just barely when a woman discovers that she's pregnant. By the time that a woman discovers she's pregnant, that's right around the time when it is too late to adjust her folic acid intake and prevent the neural tube defect. And the neural tube defect that we are referring to is either spina bifida or anencephaly. Both the US and Canada, we both have well-established fortification programs although there is no global standard. So around the world, intake can vary widely. During pregnancy, demands for folate increase due to its role in nucleic acid synthesis. To accommodate this need, the FNB recently increased the folate RDA from 400 micrograms a day for non-pregnant women to 600 micrograms a day during pregnancy. Now, this level of intake might be difficult to achieve through diet alone, and the American College of Obstetricians and Gynecologists recommends a prenatal vitamin supplement for most pregnant women just to ensure that they obtain adequate amounts of folic acid and other nutrients. The major sources of natural dietary folate are legumes, green leafy vegetables, liver, citrus fruits and juices, and whole wheat bread. It is also available in nuts, beans, peas, dairy products, poultry and meat, eggs, seafood, and grain. Spinach, liver, yeast, asparagus, and Brussels sprouts are also among the foods with the highest levels of folate. And compared to naturally occurring folate in foods, well, the synthetic form of the vitamin, which is folic acid, which is normally the form found in fortified foods and supplements, is almost twice as well absorbed. So moving on to vitamin B12. Strict vegetarians and vegans are at greater risk than lacto-ovo-vegetarians and non-vegetarians of developing vitamin B12 deficiency because natural food sources of vitamin B12 are limited to animal foods. Fortified breakfast cereals are one of the few sources of vitamin B12 from plants and can be used as a dietary source of vitamin B12 for strict vegetarians and vegans. Since vitamin B12 crosses the placenta during pregnancy and is present in breast milk, exclusively breastfed infants of women who consume no animal products may have very limited reserves of vitamin B12. They can develop vitamin B12 deficiency within months of birth. Undetected and untreated vitamin B12 deficiency in infants can result in severe and permanent neurological damage. The RDI for vitamin B12 for all women past the age of 14 for the general population is 2.4 micrograms per deciliter. For pregnant and lactating women, it jumps up a little bit at 2.6 micrograms per deciliter for pregnant women and 2.8 micrograms per deciliter for lactating women. Vitamin B12 is a water-soluble vitamin that is naturally present in some foods, added to others, and is available as a dietary supplement as well as a prescription medication. So vitamin B12 exists in several forms and contains the mineral cobalt. So compounds with the vitamin B12 activity are sometimes called cobalamins. So a healthy DNA is dependent on vitamin B12. It also helps nerve cells and red blood cells be healthy. It's naturally found in animal products, but it's particularly high in shellfish, organ meats such as liver, some game meats like venison, and other fish like sardines or trout or herring. And in the United States, primary sources of vitamin B12 are usually they're mixed dishes containing fish, meat, or poultry. They can be milk beverages and ready-to-eat fortified cereals. Usually, infants do get enough vitamin B12 through breast milk. Vitamin B12, it's a water-soluble vitamin. It's transferred through the placenta to the baby during pregnancy, as well as through human milk postpartum. Infants who consume breast milk from a mom who obtains adequate amounts of vitamin B12, or I do need to state that infants who drink infant formula will receive enough vitamin B12. However, if a breastfeeding mom is deficient in vitamin B12, there's a possibility that her infant may also become deficient. We've talked about veganism or breastfeeding moms on a strict vegetarian diet, but keep in mind that breastfeeding mothers who have had a malabsorptive bariatric procedure, such as a gastric bypass surgery, or if they've had pernicious anemia, which is a low number of red blood cells caused by a deficiency of the vitamin B12, or who have certain GI disorders, they may not be able to absorb various vitamin minerals, including vitamin B12, as well as folic acid and iron and calcium. And this is where it comes into play that it is important for moms to keep their healthcare providers in the loop. So healthcare providers should monitor these mothers for nutrient deficiencies. including vitamin B12. So the American Dietetic Association recommends supplemental vitamin B12 for vegans as well as lacto-ovo-vegetarians during both pregnancy and lactation. And hopefully that will ensure that enough vitamin B12 is transferred prenatally as well as via human milk. Pregnant and lactating women who follow strict vegetarian or vegan diets should consult with a pediatrician regarding vitamin B12 supplements for their infants and children. So vitamin D is very, very limited in nature unless you count the source of the sun. And fortified foods actually do provide most of the vitamin D in the American diet. And almost all of the U.S. supply of vitamin D is through milk, and it's voluntarily fortified. It should be noted that the vitamin D RDAs are set on the basis of minimal sun exposure, and they are 600 international units across the board. Women are at increased risk of vitamin D deficiency when they don't have a lot of exposure to sunlight, if they follow vegan diets, and if they have darker skin. And in the case of vitamin D, low levels of vitamin D during a pregnancy can actually result in the baby experiencing a deficiency as the baby does accumulate vitamin D in the prenatal period. Infants do not get enough vitamin D from breast milk. Breast milk alone does not provide infants with an adequate amount of vitamin D, even if mothers are taking vitamins containing vitamin D. Shortly after birth, most infants will need an additional source of vitamin D.
So besides its role in skeletal
It
formation,
should be noted that 400 international units daily beginning in the first few weeks of life is the recommended supplementation.
Cardiovascular disease,
supplementation should continue until the baby is weaned to at least 1 quart or around 1 liter of whole milk a day. Whole milk should not be used until after 12 months of age due to the infant's
there have been reports from the Middle
immature
East, North Africa,
gastrointestinal
Canada,
system
Australia,
and immature
England,
immunity.
US of deficiency.
Previously, supplementation was not that necessary, and many parents don't supplement, and many physicians still don't recommend supplementation.
Are recommended for the
now, while the World Health Organization recommends no sun exposure for babies under 12 months of age, the Center for Disease Control, the CDC, and the American Academy of Pediatrics, the AAP, do concede that minimal indirect sunlight and sunscreen is important. So what is sensible sun exposure?
Filter and even
Defined by the AAP, sensible sun exposure is 30 minutes a week with a diaper only, or 2 hours a week fully clothed, or 10 minutes a day, once a week.
Can increase the levels
the
of
AAP
vitamin D in
feels
breast
strongly
milk,
that all children should be kept out of direct sun as much as possible, and they should wear sunscreen while in the sun to avoid long-term risk of sun exposure, which may contribute to skin cancer.
Within about 8 weeks.
Remember, sunscreen does keep the skin from manufacturing vitamin D. All formulas sold in the United States have at least 400 international units per liter of vitamin D. So if a baby is drinking at least 32 ounces of formula a day, vitamin D supplementation is not needed. Again, whole milk should not be used until around 12 months of age.
Serum concentrations of vitamin D.
So like I said earlier, vitamin D is very limited in nature, and most of all of the vitamin D supply in the American diet is available through the U.S. milk supply and is voluntarily fortified. So vitamin D is found in fatty fish like salmon, tuna, mackerel, which are among some of the best sources. There's also beef liver, cheese, and egg yolks, which provide small amounts. Even some mushrooms do provide vitamin D. Almost all of the U.S. milk supply is fortified with 400 international units of vitamin D per quart. However, with foods made from milk, like cheese or ice cream, those specific types of milk are actually not fortified. Vitamin D is added to many breakfast cereals, like breakfast cereals seem to be a vehicle of choice for many, many nutrients. And it's also added to certain brands of orange juice. You can also find vitamin D in some yogurts and margarines and soy beverages, but you do want to always check the label. So let's move on to vitamin K. Do infants receive enough vitamin K from breast milk? No, they do not. Breast milk is low in vitamin K, and breast milk from mothers who are taking vitamin K supplements at times is also low in vitamin K. Now, infants born in the U.S. are routinely given a vitamin K injection, and this is due to low infant stores at birth per the recommendation of the AAP. Really, placenta transfer only accounts for small amounts of vitamin K. And in human milk, again, that's really doesn't contain a significant supply. And the primary gut flora, lactobacillus, which is found in breastfed infants, it just doesn't synthesize sufficient vitamin K either. So without this vitamin, blood, it doesn't clot. And if there's a wound, that means that the blood doesn't clot and just flows freely. Infants can experience hemorrhagic disease, which is rare, but it is life-threatening. Again, when I talk about how important variety, balance, and moderation is, you can see that a lot of these micronutrients come from a wide variety of sources. If you look at the sources of vitamin K, which include green leafy vegetables, vegetable oils, meat, cheese, eggs, and soybeans, as well as it being synthesized in the GI system, you can see that a diet that has a lot of variety will hit a lot of these areas. And so, again, you can't have a varied diet every single day, but over a week's time or over several days' time, you can ensure obtaining a lot of different nutrients when you have a diet that's highly varied. Name 3 sources of vitamin B12. Shellfish, organ and game meats, fish, milk, and ready-to-eat fortified cereals. What is the impact of low intake of vitamin B12 on breast milk and on the baby? Well, since vitamin B12 crosses the placenta during pregnancy and is present in breast milk, exclusively breastfed infants of women who consume no animal products may have very limited reserves of vitamin B12, and they may possibly become deficient. And on the baby, well, undetected and untreated vitamin B12 deficiency in infants can result in severe and permanent neurological damage. In the past, these vitamins were primary. They received a lot of attention. There was a lot of movement in the government to focus on these specific nutrients. And now things have shifted a little bit as more and more research has been focusing on vitamin D as well as potassium. And so in different eras, different nutrients are spotlighted. And in the past, these were certainly in the forefront. And now, whether because we found out that, we've included them in enough processed foods or people are obtaining them more and more, our focus has kind of shifted to other nutrients. However, these nutrients are still critical. As you can see, maternal vitamin A deficiency, which is seen less in the US than around the world, does impact the amount available in human milk. Vitamin A is important for visual health, immunity, fetal growth and development. So vitamin C is also a critical nutrient. It's important in terms of fetal growth and development and overall health, as well as in immunity. And the needs for vitamin C are elevated during lactation. So we have talked about calcium before, and you can see that the needs are much higher in the younger ladies. 14 to 18 years of age, the requirements across the board, whether they're non-pregnant, pregnant, or lactating, are up at 1,300 milligrams a day. 19 to 50, 1,000 milligrams across the day. Keep in mind that calcium is mobilized from the maternal skeleton during breastfeeding. Certain prenatal supplements that women may continue taking after they give birth, or even other supplements, may not have adequate calcium to supply that mobilization. Now, even though calcium is moved from the maternal skeleton into breast milk for the baby, there is significant recovery afterwards, and studies are showing that breastfeeding does impart a protective effect against later on osteoporosis. In terms of calcium supplements, one thing to remember is to improve absorption. You do want to take calcium supplements that can be divided into 2 or 3 doses and possibly taken with meals. And vitamin D does facilitate the absorption of calcium. Those two are pretty good partners. And so whenever possible, you want to recommend that a calcium supplement contain either 400 all the way up to 800 international units of vitamin D. Some good calcium supplements to recommend include calcium carbonate, which are found in calcium soft chews, Caltrate, Oscal, Tums, or Viactive, as well as other supplements. And those are pretty readily absorbed by most people. And they also are cost effective as well. Calcium citrate products, such as Citracal, can also be recommended, but again, those may be more expensive, and sometimes those you need to take more of those in order to achieve the optimal dosage. So those may not be the best frugal choice. Now, in nature, calcium is found in milk and yogurt and cheese. These are the main food sources of calcium for the majority of people in the United States. You can also find calcium in certain vegetables like Chinese cabbage, broccoli, and kale. And these are actually fairly adequate vegetable sources of calcium. Remember that in earlier lectures we talked about how even though spinach does have some calcium, that calcium is pretty poorly absorbed. Fish with soft bones that can be eaten, like canned sardines or canned salmon, are also decent sources of calcium. Breads, pastas, and unfortified cereals, while those are not necessarily rich in calcium, those do contribute significant amount to the American diet just because we consume those foods often and we consume them in large amounts. Calcium is added to some breakfast cereals and fruit juices. It's also added to certain soy and rice beverages, as well as to finding a home in tofu. So to find out whether these foods have calcium, you do need to check the product labels. So just as a side note, inulin, which is a prebiotic, it can also help with calcium absorption. So you have vitamin D and you have inulin. Inulin-rich foods, those include bananas, which again, that's a great snack to take on the road, for a quick breakfast, for a fast lunch, as well as garlic, leeks, onions, and asparagus. Those are all inulin-rich foods, again, which help with calcium absorption. Wheat is also rich in inulin. So again, the diet high in variety is important. Iodine is a vital component of thyroid hormones. The mother's thyroid hormone levels affect proper fetal growth and neurologic development during pregnancy and after birth. So iodine has a role in metabolism, protein synthesis, as well as in enzymatic activity. And it also plays a role in fetal and infant skeletal and central nervous system development. So both the American Thyroid Association as well as the American Academy of Pediatrics recommend that all women of childbearing age consume 150 micrograms of iodine daily, either from their diet or a supplement. Now, infants do usually get enough iodine from breast milk, and the recommended dietary allowance, or the RDA, is higher for women when they are pregnant or breastfeeding, just in order to support not only proper fetal growth during pregnancy, but infant growth and neurologic development afterwards. Although breast milk contains iodine, concentrations can vary based on maternal iodine levels. If a pregnant or breastfeeding woman is deficient in iodine, the fetus or infant may be at risk for iodine deficiency and associated cognitive and psychomotor impairments. So as you can see, the pre-pregnancy requirement is 150 micrograms a day. It jumps up during pregnancy to 220 micrograms a day, and in breastfeeding it soars up to 290. Not all multivitamin and prenatal supplements contain 150 micrograms of iodine. All women should check the nutrition label or check with their healthcare provider about whether their multivitamin supplement or prenatal vitamin, in the case of a prenatal woman, contains enough iodine. So who's at risk for iodine deficiency while breastfeeding? Well, there are at-risk populations, and women who don't consume enough dairy products or who smoke cigarettes, women who don't use iodized salt, and women who eat foods containing goitrogens. And those are substances that actually affect how well the thyroid gland makes the thyroid hormones. And these foods can include Brussels sprouts, kale, cabbage, cauliflower, radishes, and broccoli. Content is variable. Similar to selenium, content is variable because soil levels of iodine is variable. Now, seaweed is a decent source, but again, the content is very, very inconsistent. Now, more than 70 countries, including the US and Canada, similar to folacin, and similar to vitamin D, have salt iodization programs. Around 70% of households worldwide do use iodized salt. Around 90% of households in North and South America use iodized salt, but less than 50% of households in Europe and the Eastern Mediterranean regions use salt. In the US, salt manufacturers have been adding iodine to table salt since the 1920s, and it is still a voluntary program. Now, one would think that with the American diet and how it's completely, overwhelmed by sodium, one would think that this nutrient wouldn't be that hard to consume. However, the majority of salt intake in the United States actually comes from processed food, and the food manufacturers use non-iodized salt in most cases when processing foods. If they do use iodized salt, they will list salt as iodized in the ingredient list. Iron is one of those nutrients that actually drops. So if you look at the DRI for lactating women compared to pregnant women, you can see that it's almost cut in a third in terms of, well, it is for 19 to 50-year-olds, but it's reduced dramatically from needs during pregnancy to needs during lactation. During lactation, human milk iron levels remain constant because they are pulled from maternal iron stores. They're independent of dietary intake, but because they are pulled from maternal iron stores, that's why it's so important that during pregnancy, women do build up those reserves. For many populations in which the prevalence of anemia is higher than 20%, supplements are recommended at a rate of around 60 milligrams of elemental iron once a week for 3 months, followed by 3 months of supplementation. Then you would repeat that cycle. Full-term healthy babies receive enough iron from their mothers in the 3rd trimester of pregnancy to last for the first 4 months of life. Although the iron delivered through breast milk is in small amounts, as we've mentioned earlier, it's very satisfactory and it's very highly bioavailable. The iron stores of infants are not depleted until they are 4 to 6 months of age or even later. And even still, with that knowledge, the current recommendations from the AAP do recommend supplementation of iron. Now, that supplementation of iron may have a negative effect on breastfed infants. Lactoferrin can lose its ability to inhibit the growth of harmful bacteria when it's saturated with that exogenous supplementary iron. Iron status will naturally improve when infants, in combination with human milk, begin eating iron-rich foods at around 6 months of age. At birth, a healthy infant's hemoglobin level is around 18 to 20 milligrams per deciliter. We've talked about how as the healthy infant's hemoglobin level is high initially and then it begins dropping, but the hemoglobin is also transitioning from a fetal to an adult form, and that adult form is a very efficient transporter of iron. And so even though we see that levels do plunge, the efficiency of transport rises. So current AAP recommendations do include supplementation. For infants who are exclusively breastfed, they consider them to be at increased risk of iron deficiency after 4 months of age. The AAP recommends giving breastfed infants 1 milligram per kilogram a day of a liquid iron supplement until iron-containing solid foods are introduced at about 6 months of age. When solid foods are added to the baby's diet, they recommend to continue breastfeeding until at least 12 months. Now, for babies who are partially breastfed, well, if babies receive more than half of the daily feedings from human milk and the child is not receiving iron-containing complementary food, the iron recommendation remains the same as those for fully breastfed infants. For formula-fed infants, it's recommended that an iron-fortified formula containing around 4 to 12 milligrams of iron be used from birth through the entire first year of life. Premature babies do have fewer iron stores, and so they often need additional iron beyond what they receive from breast milk or formula because, again, most of the iron is transported through the last trimester of pregnancy. Now, looking at vegetarians, the RDA for vegetarians are much higher than for people who eat meat. Now, this is simply because, as we've talked about in other modules, the heme iron from meat is more bioavailable than the non-heme iron from plant-based foods. So therefore, meat, poultry, and seafood do increase the absorption of plant-based or non-heme iron. So animal sources of iron include heme iron, which, like we mentioned in the previous slide, is easily absorbed. You can find heme iron in meat, chicken, fish, pork, turkey, and eggs. And then there's the plant iron, which is non-heme, and that's less easily absorbed. Iron in plant sources come from beans, fortified cereal and bread, spinach, nuts, as well as dried fruits. Vitamin C, lactose, and heme iron all assist in the absorption of iron. Calcium decreases absorption. Moving on to zinc. As you can see from this slide, the RDI for lactating women is higher than those of non-pregnant and pregnant women. The reason for that is that lactation can also deplete maternal zinc stores. And for these reasons, the RDA for zinc is higher for lactating women. Food sources of zinc include meat, some shellfish, oysters, fortified cereals, legumes, nuts, and whole grains. However, bioavailability can be low in vegetarian diets due to the presence of fiber. And that fiber can really bind to zinc and decrease its absorption. Fiber at times can also, and even calcium at times can inhibit zinc absorption. So besides fiber and calcium, high intakes of supplemental iron may also inhibit zinc absorption when both are taken without food. So zinc supplementation may be prudent in any of the following conditions. If a woman has a gastrointestinal disorder that affects absorption, if there's a high intake of supplemental iron, or if cereal and plant-based diets are high in fiber. Chronic high doses of zinc can also interfere with copper absorption and suppress the immune system, as well as lower the HDL levels, which are the good cholesterol levels. So the bottom line for a lactating mom's healthy diet. Well, this quote kind of sums it up. Sorry for all the times I dropped crumbs on you while breastfeeding. It's important for moms to take care of themselves so that they can be healthy and be healthy for their children. A mom is asking if supplementation is really necessary. What would you tell her? While eating more food to meet energy needs and the increased absorption of nutrients that occurs during pregnancy are usually enough to meet the needs for most nutrients, that's dependent on when good food choices are made. Vitamin and mineral supplementation can be routine, and supplementation can help cover nutrition gaps. Many women do consume less than the recommended amount of calcium, of magnesium, zinc, vitamin B6, and folate. It is important to emphasize that vitamin and mineral supplements cannot replace a healthy diet. And overall, even if a diet is lacking in certain nutrients, and I realize this isn't on the slide, even if it's lacking in certain nutrients, the perfect milk is still breast milk, even in the face of an inadequate diet. When offering nutrition recommendations to your future clients, I would again suggest to review the dietary guidelines for Americans. And even the campaign at myplate.gov is a great resource for already made meal plans. These meal plans can be tailored to offer specific shifts that are personalized for your clients. And when in doubt, just remember the general rule of keeping half of your plate vegetables and fruits. When you're doing any meal plan, let's go over the slide. Things to consider are planning for breakfast, a snack, a lunch, a snack, and dinner. You want to incorporate in a variety of ways grains, vegetables, fruits, dairy, protein, fats, and oils. Now here are the recommendations for a 2,400 calorie diet. An additional after dinner snack, or maybe double sizing one of the snacks during the day, can be suggested. Again, the increases in red that you see are just the differences between a 2,200 calorie eating plan and this one. So the grains increase, the protein increases, and even though you're limiting these nutrients, the saturated fat and the added sugars rise a bit as well. Keep in mind that these are maximums, and eating less is perfectly fine. The choice to be vegetarian can be due to many, many reasons. There are philosophical values, there's the environment, there's culture, there's economics, and there's health. Meat really only occupied the larger space on our plates for the past few decades. Previously, meat was one of the side dishes, and other elements, other parts of the diet, like complex carbohydrates and fruits and vegetables, did occupy center stage. Vegetarians that include certain animal products, such as milk or eggs, can easily obtain all of the nutrients needed for breastfeeding. And the majority of the planet does consume this type of diet. A balanced vegetarian diet is very healthy. It also can provide additional benefits like decreasing excess weight gain due to the fact that you're usually getting fewer calories as well as less fat. A constipation, which can be a common side effect even after pregnancy, can be reduced in this type of a diet just because there's usually extra fiber taken in. Now, the difficulty can arise if a vegetarian woman doesn't really manage her diet well. Now, most vegetarians are completely comfortable and knowledgeable about obtaining a balanced diet. They know where their protein is, they know where their nutrients are, but highly restrictive vegetarians or those following other strict regimens may benefit from an RDN consult and should keep her healthcare provider informed of her decision. Keep in mind some of the nutrients that may be low, and these are listed on the slide. We talked about protein. Protein can be low. Vitamin B12 can be low. Vitamin D may be low, especially if a woman is not consuming vitamin D fortified milk or dairy products. That can be low as well. The same thing with calcium. Women who are vegans may not have enough calcium in their diet as well. Iron is another nutrient that may be low in vegetarian diets. Remember that we said earlier that the American Dietetic Association does recommend supplemental vitamin B12 for vegans, as well as other women who follow a strict diet during pregnancy as well as during lactation, and that's just to ensure that enough vitamin B12 is transferred to the baby. And if women are following strict vegetarian or vegan diets, they do want to check in with their pediatrician and just see if they do recommend a vitamin B12 supplement for their infants or children. So there are a number of considerations when addressing the prenatal or lactating woman's diet. Many of those we've covered to a certain extent during the Nutrition During Pregnancy module, but we'll cover those specifically in how it relates to lactation here. There is cultural avoidance, flavor issues, common food allergens, alcohol, as well as caffeine. So eczema, highly allergenic foods, caffeine, herbs, alcohol, taste preferences, and artificial sweeteners all have an effect on maternal food intake in one way or another, and we'll be discussing those in the coming minutes. So first off, let's look at the foods that a lot of moms will have questions about. Gassy foods. So common culprits include beans, broccoli, cabbage, and Brussels sprouts. Bloating, burping, and passing gas are normal. If a baby is gassy or has colic, you might want to suggest to the mom that she avoid these foods for a couple of weeks to see whether or not they relieve the symptoms. Again, I've mentioned this earlier, but getting rid of beans, broccoli, cabbage, and Brussels sprouts, there are a lot of other foods that can fill in those nutritional gaps. So just taking out 4 or 5 foods that they may suspect is an issue isn't a big deal if they replace them with something that provides those same nutrients. So sugary drinks. So we've talked about the importance of water in terms of a lactating mom. And water is always the beverage of choice. Sugary drinks can add a lot of additional calories without adding nutritional benefits to a mom's diet. And again, we do want mom to return to her postpartum weight so that she can possibly begin a future pregnancy in the best health possible, or regain her pre-pregnancy weight as a matter of ongoing health. So some highly allergenic foods like eggs, peanuts, and nuts, some of these foods are avoided by moms because they believe that if they avoid them while they're breastfeeding, that can help their baby not become allergic to those foods in the future. But there is just no proof that exists. There's no reason for moms to avoid these foods unless she herself is allergic, or if by a trial the baby's been found to be allergic to these foods. So milk and other forms of dairy, it's rarely a problem. If the mom is lactose intolerant or has a milk allergy herself, then of course those foods can be avoided or modified in terms of a lactose intolerance. But Moms should always be cautioned to just pay attention to how their baby does. If the baby has skin issues or trouble breathing or diarrhea or other GI issues, all moms should be on the lookout for those symptoms. Usually, when it's recommended that a breastfeeding mom eliminate dairy products from her diet, it's because of a problem that may be caused by the protein, not because of a lactose intolerance. Remember, human milk is full of lactose. Nature is made it pretty clear that babies and toddlers can really digest lactose easily. If a mom does suspect that a baby is sensitive to a cow's milk protein in her diet, again, same thing as before. She can eliminate that food for around 21 days, again, to make sure that all traces of that cow's milk protein is gone and out of her system. And then she can see how her baby reacts to her current non-milk or non-dairy diet. Some babies do react well if dairy products are removed, like milk and yogurt, cheese, cream, ice cream, but others really don't show any improvement unless every single trace of cow's milk is eliminated. In that case, moms would really need to identify and eliminate hidden sources. But again, most moms can tolerate easily, as long as they can tolerate. Most moms can tolerate milk and dairy. And again, with spicy foods. So most babies can handle spicy food, and most babies can handle other fiery foods. But if a mom does suspect that a little one is gassy or colicky, or they have GI issues like diarrhea, then again, just cut back on those spicy foods, and mom will have to push those off into the future when she's not lactating. But again, eliminating these foods, that won't be a nutritional issue to the mom. That'll be more of a taste issue for the mom. So in the past, some parents avoided allergenic foods when there was a family history. However, most foods are considered acceptable unless they cause allergic reactions in the parent or the mom consumes them in excessive amounts. Highly allergenic foods like milk, eggs, wheat, and peanuts do not necessarily need to be avoided unless the mother is allergic. Other nutritious options should be chosen. Generally, infants should not have those foods until after 1 year of age, along with egg whites, seafood, corn, and honey. Again, no food needs to be avoided unless there's a specific reaction like fussiness. Within a month or two, the infant's digestive system will mature and the food may be introduced, and chances are the food will be well accepted. For the mother, if she is allergic to dairy products, there is a wide variety of non-dairy calcium-rich foods. Keep in mind, there are a lot of milks on the market shelf these days, and they are not all the same. This is where reading the label and determining if it's a good source of calcium, vitamin D, or protein is important. They won't all be. Obtaining calcium is possible without taking a supplement. If a calcium supplement is used, it should be taken 2 hours separately from iron-rich foods or iron supplements, as they do compete against each other in the body. Calcium also prefers to have vitamin D around to increase absorption, which is why it's convenient to take those supplements together. Consider them kind of like food partners. Crying is one of the main ways that infants communicate, and a baby's loud wails will let parents know if they are wet, if they are hungry, if they are tired, if they are overtired, if they're uncomfortable, if they're sick, if they're the list goes on and on. Parents really do need to identify the source of the crying, and a lot of parents, as a general rule, do assume right off the bat that a baby is hungry. Once the need in question is taken care of, the baby should calm down. Some babies keep crying long after they've been fed or they've been changed and cared for. And instead of calming down, they kind of ramp up. They cry even more intensely. And sometimes babies pull up their legs. Sometimes they pass gas. There are a lot of different ways that colic, which is what we're talking about, that colic can exhibit itself. Colic is defined as inconsolable crying with or without gas. Over time, babies do develop their own rhythm of crying. They also develop their own rhythm of feeding, of sleeping, and of playing, and of communicating, and parents will learn to interpret the different cries. However, there are still times when they have variations in their schedule that really include moments of hard crying. Despite the universalness and frustration that accompany colic, the exact etiology of colic is unknown. Effective treatments really remain elusive. With minimal quality evidence to support interventions for colicky infants, we often, really have nothing to rely on. We look at old wives' tales or other advice, which usually isn't very helpful. This is a very exasperating condition, and it really doesn't have very many remedies. The good news about this is colic usually isn't a sign of anything serious, although it is very common, and up to 30 to 40% of infants have crying spells. The crying spells should subside within a few months. Babies who have colic, well, they can start crying for no obvious reason. They start crying suddenly. They often cry in the early evening, although the crying can start at any time of the day. They can cry for more than 3 hours a day, on more than 3 days a week, for more than 3 weeks. And that's where that rule of 3-3-3 comes into play. Sometimes they have a swollen belly, and they may pull up their legs to their chest and pass gas. And babies are often hard to soothe. So to recap, colic is defined as a state of fussiness or crying that lasts for more than 3 hours a day for at least 3 days a week, over a period of about 3 weeks or more. Again, it usually starts around week 3 and ends around 3 months of age. And 3 months of age is that point when babies are thought to generally be more able to self-soothe. Doctors aren't really sure what causes colic, and we mentioned that earlier, but babies who have colic may become easily overwhelmed by lights and sound and just other stimulation. They may be more sensitive to a food that their mother is eating, such as soy or dairy, if they're having trouble breastfeeding. They may be more sensitive to a food that their mother is eating, like soy or dairy, during breastfeeding. They may have trouble consoling themselves or self-soothing. And keep in mind that colic isn't an illness, although some babies do cry a lot when they're sick. Now, we really don't know which babies get colic. Any baby can get colic. It doesn't matter whether the baby is breastfed or whether they're bottle fed. About the same number do get colic, and about the same number of baby boys and baby girls get colic. Babies may be more likely to get colic if they eat too much or too little, if they eat too quickly or swallow too much air while nursing, which causes gas. They may be more likely to get colic if they have an allergy to formula or to a food in their mom's diet if, again, they're breastfed. If they live in a stressful environment, sometimes that can make babies more prone to be colicky. If they start eating cereal too early, that can be another trigger at around 4 months of age. However, keep in mind that none of these characteristics or situations may be present, and the baby may still be colicky. In regards to maternal food intake and colic, keep in mind a few principles. The number one reason for visits to the pediatrician are crying, incessant, persistent crying, and parents often perceive incorrectly that the inconsolable crying is either a sign of a serious illness or a result of poor parenting skills. The reality is that most pediatricians will still want to see the baby. They want to rule out other issues or conditions that the baby may have. So if a mom is concerned and does want, a pediatrician to look at the baby because she feels like he's crying too much, that is completely okay. Again, we want to rule out other issues. Some recommended options to try resolving the situation with colic may be swaddling, using a snug swaddle. An infant may feel more secure when they're wrapped up snugly. Other options may be white noise. Sounds like a vacuum or other repetitive or rhythmic sounds may be soothing. Even things like radio static, a running shower, a special white noise machine, a washing machine may really help with reducing the other stimulation that a baby is feeling. Some babies may be helped out by a different position. A different position may help as well. Changing position for a baby to a new position may help calm her down. Or having a baby be given a massage by laying her, tummy down across knees, rubbing her back. Those may help as well. Or just a simple walk in the evening. Colic often occurs in the early evening, and if a mom just wants to take her baby out for a walk around the neighborhood with a stroller, sometimes that fresh air, that outside environment may really help. Unfortunately, a colicky baby may not respond at all to any calming methods. Now let's look at diet. So in terms of diet, current guidelines recommend really only one strategy for breastfeeding moms. This is the case where sometimes a low allergen diet may be recommended. And again, this may or may not work. Recent studies do suggest that low counts of intestinal lactobacilli may actually play a role in colic, and some do have documented improved symptoms after treatment with lactobacilli when compared with other treatments. More studies are needed to determine if additional lactobacilli during breastfeeding will assist with treating colic. And this is where we are going to wave the flag on caffeine, because caffeine may in fact play a role. A cup of coffee or other containing beverage, usually that's okay, but some babies are simply more sensitive than others, and they may experience that jitteriness. Certain caffeine-containing beverages these days are super high in caffeine. Even certain coffee brands are marketed due to their high caffeine content, and one shot of espresso that can really sometimes push a baby over the edge. Now, reducing caffeine may or may not make a difference, but it is worth trying. Now, just circling back around to allergenic foods and the role of colic, although there is little evidence to support the avoidance of certain foods during lactation, again, unless the mom is allergic, like with cow's milk or wheat, nuts, or other common allergens, some mothers do report specific foods causing their infant distress. Acknowledging the information and supporting the mom is key. And unless there's a significant avoidance of a food group, eliminating certain specific nutrients here and there is generally not going to be detrimental to the health of the mom. If she avoids Brussels sprouts, well, there are a lot of other foods that can fill that nutritional gap. Onions she's avoiding, okay, again, that's not going to cause her to be deficient in a certain nutrient. Mom should also be cautioned that, this may or may not be a factor in future babies. All babies are different, and, some babies are sensitive to certain foods and others aren't. So just because in her lactation experience with one baby, she finds, a certain food might trigger a response, it doesn't mean that subsequent lactation experiences are going to be the same. One final note about dairy, that if a mom is looking to remove dairy, this would be the elimination of an entire food group. And, eliminating milk and cheese and yogurt and cottage cheese, there are other ways to obtain calcium and protein. But if they're looking at eliminating dairy completely, this is again where label reading is critical. Dairy can hide out in many products. There's pizza, cheese crackers, creamy salad dressings, cheesy salad dressings, smoothies. Even, remember we talked about casein and whey, which are the proteins in dairy. Those may appear in certain foods. And so positive results have been observed when mothers who recognize that dairy may be an issue with infants who test positively for a skin test for milk allergy. When moms realize that the dairy is kind of the culprit there, she really does need to examine food labels carefully in order to identify, those really stealth dairy products. Out there about colic, there are a lot of home remedies that people try that are supposed to relieve colic and they don't. Most aren't proven, and some of them could actually hurt the baby. And again, the pediatrician should always, just be consulted to rule out other issues, but never should moms try, these following things, like rice in a bottle. That's a huge no-no. It's a big choking hazard. It can destroy satiety cues. It can lead to an overweight baby, and it just isn't proven to work. Other herbal remedies like chamomile or what's called gripe water, the FDA doesn't regulate over-the-counter remedies. We're really not sure what is in a lot of different herbal preparations, and ingredients aren't always labeled. Some of these can have things in them that are definitely harmful, like alcohol or even opiates. So simethicone gas drops, well, these might be okay to try. Not sure if they'll work. They have been seen to work in some babies, but not in all. Again, they may or may not help, but again, just checking in with the doctor, verify that this is something that the mom would want to try would be a good idea. While most mothers eat a wide variety of food, there are many cultures around the planet that have specific foods they avoid for a number of reasons. Some cultures embrace certain foods that are shunned by others. Some foods that are avoided may be high in fiber, acidic fruits, gas-forming vegetables and beans, milk, certain spices, and sometimes even chocolate. Some others believe that certain foods affect her baby negatively, and it's fine to restrict or omit a certain food for, a certain period of time, and they can usually be resumed when culturally it's appropriate for them. Again, we're talking about very specific foods, not eliminating entire food groups. Usually, these foods can be offered to baby at later time without any issues. Again, all food is really generally fine for the mom to eat. If a mom feels strongly about a certain food, again, that's okay. They just need to ensure that she's receiving a balanced diet. Studies demonstrate that children have increased acceptance of foods later in life when eaten by their lactating moms. And this also comes into play when we're looking at issues like alcohol. The flavor of foods and drinks do seep into breast milk, and studies have found that breastfed infants breastfeed longer when moms have diets high in garlic or vanilla. So it's just kind of a fun fact to keep in mind. New moms everywhere are in search of natural ways to boost milk supply. Current trends in maternal health, such as the increasing rates of obesity, delayed age at childbearing, and the high rates of C-sections are all considerations, and these all lead to delayed lactogenesis. Women who are not enjoying breastfeeding success may seek out ways to induce lactation or may seek out ways to increase the quantity of her breast milk, and they may turn to galactagogues or other lactogenic foods. And a galactagogue is an herb that is thought to help increase breast milk production in nursing moms. Every culture has them. There are no studies to indicate that they're effective, and we've mentioned before that many moms will, in the interest in pursuing optimal nutrition, try many, many things. And some things they try are good, and some things that they try are not good. So many herbs and supplements are in fact unsafe, or they may mask the symptoms of a legitimate condition or illness. There are two herbs that are commonly thought to be lactogenic. Some women may find these helpful and some may not. And keep in mind that there's something called the placebo effect. The placebo effect is a beneficial effect produced by a placebo drug or treatment that can't be attributed to the properties of the placebo itself, and therefore must be due to the patient's belief in that treatment. So clinically, the drug or the treatment or the herb doesn't really have any way to fix what's going on, but just the pure belief in the ability of that constituent to improve lactation or improve the quantity of lactation is in itself enough to boost milk supply. Again, most cases of insufficient milk supply are due to insufficient or ineffective breastfeeding. For example, fenugreek is believed to raise maternal prolactin levels. If a mom's prolactin levels are generally normal, fenugreek will not help, nor will any other medication help. If a mom's prolactin levels are normal, they're normal. Moringa is in the same category. Again, moms should really be encouraged, and counseling really does need to address effective breastfeeding practices. So your text does list www.lowmilksupply.org as a reliable source to determine whether or not a galactagogue may be appropriate. Again, moms should always inform, their physician as well as the baby's physician about what they're taking. Same thing here. Any herbs, teas, or home remedies should be discussed with a healthcare provider. As mentioned earlier, some can be toxic and unsafe. Let's look at low carbohydrate diets. So low carbohydrate diets are very, very popular. Now, a healthy low carbohydrate diet can be compatible with breastfeeding, but there are a few things to consider. Keep in mind, there is no official definition of a low carb diet. Most advise curbing or eliminating some or all grains, fruits, legumes, and vegetables. Many people, especially preteens and adolescents, may be particularly interested in trying carbohydrate restricting diets due to the appeal of promised weight loss. Personally, I am wary of any diet that eliminates or overemphasizes one macronutrient or food groups. Again, experts recommend a little more than about half of the calories consumed should come from carbohydrates. There are many nutritious foods, whole grains, fruits, vegetables, non-fat milk products, lean milk products, contain carbohydrates, which are the body's preferred energy source. Carbohydrates are also found in foods such as sugary beverages, candy, and baked goods. They're also found in overly processed foods. Now, limiting those types of carbohydrate-containing foods is beneficial, and that may indeed lead to weight loss. Again, parents are role models, and while they may function fine with a low-carbohydrate diet, children and teenagers do need carbohydrates from whole grains, fresh fruits, and dairy. Their intake of these food groups is vital to their growth and development, and restricting these foods can make children and teenagers feel sluggish or cranky. Decreasing healthy carbohydrates, popular in some trendy current diet models, that doesn't leave much to eat, and it really eliminates a vast number of micronutrients that are critical to health and wellness. Eating fewer carbohydrates may produce weight loss, but including certain carbohydrate-containing foods actually helps promote a healthy weight. We've talked about whole grains. Whole grains like brown rice, well, those are digested more slowly than refined grains like white rice, and those will actually prevent hunger because it just takes longer for them to be digested. Fiber, calcium, and vitamin D, those are 3 important nutrients that many children and teens lack, and those are found in carbohydrate-rich foods. Instead of avoiding all carbohydrate-containing foods, it's better for children and adults to get into the habit of eating healthier choices, whole grains, vegetables, fruits, and non-fat or lean dairy. Returning to their pre-pregnancy weight is a common interest among postpartum women. Many women feel societal pressure enforced by images of postpartum celebrities who appear to return to their former figures swiftly and effortlessly, to lose weight and get back into shape quickly after giving birth. With a healthy diet and exercise, much of the weight that women gain during pregnancy will be shed naturally during the first year postpartum. The goal should be gradual weight loss. For all but these women with high or very high pre-pregnancy weights, the recommended weight loss after the first month postpartum is around 4.5 pounds a month, or maybe a little bit more. Caloric intake should not fall below 1,800 calories a day, and this figure may need to be revised upward on the basis of such consideration of breastfeeding multiples or nutritional status or length of activity. Inadequate caloric intake may increase postpartum fatigue and may have a negative impact on mood. Many women are faced with extra weight after the pregnancy is over. 15 to 20% retain 5 or more kilograms, or around 11 pounds of gestational weight gain, increasing the risk of cumulative weight gain and the resulting health risks. Eating more calories than are burned results in weight gain. Eating less calories than are burned results in weight loss. Shifting from high-calorie foods to low-calorie foods will help with postpartum weight loss. An example would be choosing water over soda or non-fat dairy over low-fat dairy. The dietary guidelines can be very helpful when crafting recommendations. Women who are severely restricting their diet due to a focus on weight should consider a supplement. Weight loss should not be promoted as a benefit of breastfeeding. Often, instructing lactating women to focus on nutritional foods and exercise and to eat to satisfy their hunger will result in the desired slow pattern of weight loss. Again, around 0.5 pound to 2 pounds a week, or 4.5 pounds or a little bit more over the course of a month. That's generally the acceptable way to go. Again, the best way to lower calories is to limit the calories from added sugars and saturated fats. Again, those are found in foods like soft drinks and desserts, fried foods, cheese, whole milk, and fatty meats. Choosing foods that are low fat or non-fat or fat-free, choosing whole grains, or again, going back to the tried and true myplate.gov campaign of keeping half of a plate fresh fruits or vegetables is really the ideal weight maintenance program. And again, the entire family will benefit from these choices. If weight loss is happening too quickly and more calories are needed, again, eating a little more from each food group or adding an additional snack should do the trick, not necessarily choosing foods that are, the whole foods, the fried foods. You don't want to go back and choose foods that are less nutritious. You just want to eat a little bit more of the nutritious foods. And if a mom comes to you with an extreme diet, like a liquid diet, or again, diets that eliminate entire food groups, those diets should be avoided. But again, that's my recommendation no matter what stage of life a mom is in, not necessarily because she's breastfeeding. Now, when you look at postpartum weight loss, exercise is key, and exercise should be an ongoing part of any lifestyle. When it comes to postpartum weight loss, there are really 2 considerations: exercise and healthy eating patterns. In the module Basic Nutrition and Nutrition Education, we went over the dietary guidelines in detail, but we'll cover them briefly in this module as well. The bottom line for weight loss, you want to limit calories from added sugars and saturated fats, and you want to make half of your plate fruits and vegetables. Looking specifically at exercise, unless a healthcare provider identifies a medical reason that precludes physical activity, breastfeeding women can be encouraged to participate in at least 150 minutes of moderate intensity aerobic activity per week, ideally spread throughout the week. They can do 22 to 30 minutes of moderately intense exercise on most days. Exercise isn't just important for weight loss, but it's also important physically and emotionally. Exercise does help with stress reduction, and even when parents live in places where it's difficult to be outside, there are a number of ways to be active inside. Strenuous exercise of greater than 1 hour a day may require additional calories to support lactation, and again, breast refusal due to lactic acid buildup has been refuted by recent studies. A mom is concerned about her baby's reacting to the mom's intake of milk. She isn't allergic to milk. What suggestions would you offer? Well, all foods can be enjoyed. If the infant shows a reaction, then you can start to eliminate foods, beginning with milk, wheat, nuts, eggs, etc. It may take up to 21 days for the offending food to leave the system completely, but if the infant benefits from the removal of the food, that's okay. If there's no difference, a slow reintroduction is fine. What are the recommendations for postpartum exercising? Moms should exercise at least 150 minutes a week of moderate intensity workouts. It can be 4 to 6 times a week, anywhere from 22 to 30 minutes for each session, and they should begin 6 to 8 weeks postpartum with the release from a doctor. Many women are faced with extra weight once the pregnancy is over. What is the recommended amount of weight loss per week? So the recommended weight loss per week is around 1/2 pound to 2 pounds a week. Eating disorders are a group of conditions marked by an unhealthy relationship with food. The 3 main types are anorexia, bulimia, and binge eating disorders. Eating disorders are a serious medical problem that can have long-term health consequences if left untreated. Eating disorders in children and teens can lead to a host of serious physical problems and even death. And breast milk quality may be a concern for certain anorexic individuals, specifically in regards to the quantity of water-soluble vitamins, lactose, and fat. There's little data on bulimic individuals. If you suspect or recognize that one of your clients has an eating disorder, it's imperative that she seek competent medical help. Even among nutrition professionals, eating disorders are a specialty, and they're treated with a team of specialists. Many RDNs do not specialize in this area, but they will refer to ones that do. Eating disorders are less of a nutrition issue than an emotional or physical one. When moms are breastfeeding multiples, they should avoid doubling their nutrient intake. While people do want to avoid excessive weight loss or gain, it is unnecessary and unwise to recommend doubling of anything, be it supplements or other nutrients. The mom should be encouraged to follow, meaningful eating patterns and to let her hunger be her guide. Fluid intake may actually be more important in these cases, and while drinking more may not help with milk production, they do need to ensure that they meet the recommended amount daily. So I did mention this during the pregnancy during nutrition module, but I did want to re-emphasize again that around half of the pregnancies in the United States are unplanned, and often women who are breastfeeding one little one can find themselves pregnant with another. And while nutrient needs are increased during the 2nd and 3rd trimesters, again, the same thing with breastfeeding multiples. You don't need to double supplements. That's just not indicated. Moms should be cautioned that sometimes spontaneous weaning occurs, and, they do need to be prepared that at times an older baby or a toddler who is breastfeeding may start rejecting the breast. Again, they do need to check in with their healthcare provider and let them know that they are, breastfeeding during their pregnancy. So factors such as frequency of breastfeeding, age, and the health and condition of the mom and the baby should be considered when it comes to breastfeeding during pregnancy. But again, if a mom is healthy and if she's eating well and all things considered are fine, again, she just follows the regular healthy eating plan, maybe bumping her calories up a little bit in this situation. So tandem nursing follows the same guidelines. When a woman nurses 2 children of different ages, it's called tandem nursing, and producing milk for 2 children does require more calories and nutrients than needed to feed one, just again like breastfeeding multiples. An additional 500 calories a day should be sufficient to meet the demands of extra milk production. High calorie and high nutrient foods and snacks and meals do provide good sources of additional calorie intake. And again, here, what moms need to look at is not necessarily increasing any food, but making sure that the foods that she is increasing are nutrient dense. So foods like, avocados or nuts, nut butters, seeds, seed butters, dried fruits, full fat soy products, bean spreads, and, foods with omega-3 fatty acids. Those are all really good selections that will provide additional calories, but also provide additional natural nutrition. Making sure that women are hydrated is also a factor. And again, it's just letting thirst be her guide, making sure that she is, considering having a glass of water, at every meal or snack. And again, making sure that she does, check her, urination. Is her urine clear or mostly clear throughout the day? Due to high mercury levels, what foods should be avoided during pregnancy, lactation, and early childhood? So foods to be avoided are king mackerel, marlin, orange roughy, shark, swordfish, tilefish, and big-eye tuna. What nutrition recommendations would you give a mom who is tandem breastfeeding? So high-calorie and nutrient-dense foods and snacks and meals provide good sources of additional calorie intake. Again, you don't want to go for high-fat choices or added sugars. It's the nutrient-dense, healthy foods like avocado, nuts and nut butters, seeds and seed butters, dried fruits, full-fat soy products, bean spreads, and omega-3 fatty acid sources. And again, making sure mom is hydrated is really important. So healthy food choices during lactation is important for mom and baby. And again, practical and specific food suggestions are important. Working with pregnant moms to determine specific and practical nutrition goals and helping them understand the whys behind dietary suggestions is key. And this actually helps moms be more compliant. You can provide the most spot-on, helpful recommendations, but if they're not practiced, it doesn't matter. Helping families understand that healthy eating is compatible with limited budgets is also really important. Healthy eating patterns offering a strong pathway to positive lactation outcomes can include special diets like vegetarianism. Empowering women to eat well and provide good nutrition for their families is important to future generational well-being. We talked about all of these in length during the Nutrition During Pregnancy module, but I just want to reemphasize the fact that there are many factors that affect diet. Dietary background, health, family situations, housing, culture, income, and dietary practices all affect a mom's food choices. Again, items like time, priority, cravings, money, availability, culture, emotional comfort, location, and nutrition all come into play when we're looking at a mom's nutritional status. In the Pregnancy During Nutrition module, we had you plan out a 2,400 calorie diet. And while that was helpful, I hope, again, that was basically food choices. That wasn't taking into consideration a mom's time or what her priorities may be, what her cravings are, what money is available, what food is available, what her cultural influences might be, what foods provide her with some emotional comfort, is there availability of fresh produce, and what are the nutritional components that she may be looking at. These are all factors that need to be woven in when planning someone's diet. So suggestions that are specific and measurable have a higher chance of success. And suggesting that women, drink less caffeine, that's not as meaningful as, try swapping out your soda for flavored sparkling water at least 3 times a week. Or asking, what do you think you can do in order to, swap out your soda? Or asking, instead of soda, what are things that you think you could try? We know that diet and health are deeply connected. Only tobacco and alcohol intake influence health more. Of the leading causes of death, heart disease, cancer, stroke, and diabetes, 4 are related to diet. Again, other factors are important, genetics, activity level, but there are a number of diseases and conditions that are influenced and possibly preventable with healthy eating patterns. It's a spectrum. Some conditions are completely hereditary, and some are completely nutrition related, but there are many, many others in the middle of the spectrum that are influenced by both to a different degree. So when we look at the effect of maternal food intake on lactation, this is a statement from the American Academy of Pediatrics. The only true contraindications to breastfeeding are the following: infants with galactic galactosemia and mothers in the United States who are infected with HIV. Breastfeeding is not contraindicated with the following conditions: bacteremia, diarrhea, a respiratory tract infection, necrotizing enterocolitis, otitis media, a urinary tract infection, late onset sepsis in preterm infants, type 1 and type 2 diabetes, lymphoma, leukemia, Hodgkin's disease, and childhood weight and obesity. There are maternal health benefits to breastfeeding, such as decreased postpartum bleeding and more rapid uterine involution, decreased menstrual blood loss and increased child spacing, earlier return to pre-pregnancy weight, and decreased risk of breast and ovarian cancers. Breastfeeding is also a great environmental benefit. It's also a great benefit to society. Breastfeeding families are sick less often, and the parents miss less work. It doesn't require the use of energy for manufacturing, or it doesn't create waste or air pollution. There's also no risk of contamination, and it's always the right temperature, and it's always ready to feed. And yet, formula feeding in our country and around the globe remains the norm. So when we look at the effect of maternal food intake on breastfeeding, increasing maternal energy and fluid does not influence milk volume unless significant maternal malnourishment exists. Stress is more likely to be a factor in terms of quantity of breastfeeding than all others. Remember, culture can play a large role in lactation, and some cultural traditions limit the mother's foods for a few weeks. Most cultures do not have such restrictions. You need to ascertain the power that culture has in each specific family. In some families, cultural traditions may be discarded, and in others, you will need to find a workaround and solve the issue within that cultural practice. So caffeine also passes to the infant through breast milk. Infants do not have the capacity to metabolize this stimulant well, and they may be fussy or alert. Now, generally, a daily cup of coffee or a tea or soda will be fine, and most infants can handle those. Again, water is always the preferred beverage, and a woman's thirst can generally be her guide. And again, with the exception of the first morning urination, if urine is pale yellow or clear, that should indicate adequate hydration. Caffeine content varies wildly, and moms really do need to investigate how much caffeine they're actually taking. And usually we say a cup of coffee a day is fine, but a cup of coffee would be, a 5-ounce coffee cup. And for most people, 5 ounces is very, very small. Most people ingest much more than simply 5 ounces of coffee. And again, one 5-ounce cup of coffee may have 200 milligrams, while another one may have, 450 milligrams. Coffee does have the most caffeine, but also, there are energy drinks, soda, and black and green teas. Chocolate also has caffeine, but again, in much smaller amounts, and even some medications have caffeine. Herbal teas can be an option, as they're generally caffeine-free and harmless to the infant, but there are herbs that should be avoided, and these include chaparral, comfrey, germander, pennyroyal, and blue cohosh, as those are detrimental to an infant. Herbs aren't regulated by the FDA, and often the origin and conditions of growth of herbs are unknown, and they also may be contaminated by alcohol or opiates. Now, artificial sweeteners can be used. There's generally no restrictions on these if they're used moderately. Again, there's really no hard evidence that they prevent overweight or obesity, but individually they can be used as a tool to cut back on sugar. Phenylalanine, known as PKU, is an inherited disorder that increases the levels of a substance called phenylalanine in the blood. And phenylalanine is a building block of proteins. It's an amino acid that's obtained through the diet. And it's found in all proteins and in some artificial sweeteners. In this case, aspartame should be avoided. It breaks down into phenylalanine, and phenylalanine builds up and can cause developmental delay. Products containing these amino acids carry a warning label, and in this situation, moms are generally seeing a registered dietitian nutritionist in order to, build a specific diet plan. Teens may have diets that are low in iron, calcium, and other nutrients, either because of poor intake, because they follow the typical American diet, or they may have socioeconomic or family issues. So teens often skip meals, especially breakfast, and they often have a typical teen diet of inadequate vegetable and fruit intake. Even teens living above the poverty level still really don't consume the recommended amount of fruits or vegetables. And this is a priority, especially for those teens that are less than 4 years from the onset of menstruation. Young teens do need to account for their own growth needs. They also need to account for those of their baby. Teens should be encouraged to breastfeed for all of the physiological and emotional benefits that breastfeeding has to offer for her and the baby. A healthy diet becomes even more important for mom and baby for a successful outcome for both. And the specific nutrients that teens need to look out for are low iron, low folic acid, and low calcium. A breastfeeding mom is worried about drinking too much coffee. What would you tell her? A daily cup of coffee, tea, or soda will be fine for most infants to handle. Water is always the preferred beverage, and you should watch the infant for signs of fussiness, irritability, and difficulty sleeping. What are special considerations to look out for when counseling a teen mom? Well, the teen may still be growing. She has a higher risk of nutrient deficiencies like low iron, low folic acid, and low calcium, and she has a higher risk of lack of nutrition knowledge and low vegetable and fruit intake. We are what we eat, and we are what our mother and her mother and her mother ate as well. In the slides following, I've included a number of quality, reliable resources for you to refer to. In the age of Google, it's very easy for people to amass an immense amount of information, and not all of it is quality. So it really is important for you to maintain a reliable library of sources that you can go to. And again, thank you.